Hello, my name is Dr. Felicity Knight and I'm here today on behalf of the Migrant Health Research Group at St George's University London, presenting on the impact of the COVID-19 pandemic on migrants' access to primary care and implications for COVID-19 vaccine rollout. So why is this an important issue? Well, we already know that migrants face many barriers to accessing primary care, including confusion around the NHS system, language barriers, and in some cases, unfortunately, discrimination. As those of us working in primary care are well aware, the pandemic has led to some really significant changes in service delivery, including rapid digitalisation, and there have been concerns that this would disproportionately affect marginalised groups and amplify structural inequalities. However, before this study, there was very little detailed data on the impact on migrant patients. Therefore, the aims of our study were to understand and explore the views of primary care professionals and migrant patients on the impact of the pandemic on migrants and their access, consider implications for COVID-19 vaccine uptake, and potential solutions to this. So what did we do? We conducted an in-depth qualitative study using interviews by phone between June and November 2020. We sampled across a range of practice sizes and locations across England and analysed our data iteratively, informed by thematic analysis. We interviewed 64 healthcare professionals in two phases, the first phase involving clinical staff and the second phase involving administrative staff, the breakdown of which can be seen on the slide. In our third phase, we importantly explored the views of migrant patients themselves, recruiting 17 migrants, the majority of whom were asylum seekers. So what did we learn? Well, firstly, we found that digitalisation has exacerbated existing inequalities in access for many migrants, as was feared. The increased use of technology has proved a real problem for many migrant patients who lack access or knowledge of how to use technology. One patient, for example, cited that in order to register at her GP's, she had to download a form, sign it, scan it and send it back in, or use an electronic signature. Since she didn't have a printer or scanner or know how to access them, and she wasn't sure how to use an electronic signature, this was an insurmountable barrier for her, whereas it might only be a hassle for many of us. And unfortunately, these changes have led to reports of a reduction in migrant registration and attendance in some practices. Language barriers were also felt to be significant, with clinicians reporting challenges in three-way virtual consultations, and some clinicians reporting they did not know how to conduct a telephone or video consultation with an interpreter. There were also concerns about difficulties building trust and rapport, confidentiality issues, and safeguarding cues being missed in virtual consultations. A number of individuals did also report concerns about the socio-economic situation for migrants during the pandemic. One migrant mentioned that she lives on £5 to £6 a day for her family, and the additional costs of hand sanitizer and masks, etc. were really difficult for her budget. And many migrants reported worsening mental health issues, particularly brought on by living in cramped hostel accommodation. Trust was also a significant barrier, with many migrants and clinicians concerned about mistrust of UK government and healthcare systems. Migrants often reported seeking advice from peers, community members or religious leaders in preference to their GP, even having been in the country for many years. There were also concerns about a one-size-fits-all rigid approach, which didn't have flexibility in bringing patients in where required, and some migrants reported the physical closure of surgeries had significantly disadvantaged them, as they weren't able to seek advice from receptionists. And receptionists often supported in signposting to other organisations, third sector organisations, or interventions such as screening. And this was no longer available due to the physical closure, leading to indirect discrimination of migrant patients. We also had a number of findings which were very relevant for the COVID-19 vaccine rollout. We found that pre-existing distrust of vaccinations and low health literacy, alongside widespread misinformation, could negatively affect uptake in some migrant groups. This was due not only to mistrust of the UK doctors and authorities, as already mentioned, with migrants seeking input into their decision-making from their peers or social media, and in some cases religious leaders, but also a lack of language-appropriate information about the vaccine and COVID-19 targeted and tailored towards migrants. There were also a number of specific beliefs reported about COVID-19, including it being a hoax, a European infection, or that natural remedies could protect against the virus. And there were also specific fears reported around the vaccines. These included fears about being used as guinea pigs or discriminated against, as well as fears about being controlled. So why does this all matter? Well, this study took place before any COVID-19 vaccines were approved. However, we have seen disproportionate levels of vaccine hesitancy in some Black and minority ethnic groups, which does overlap with migrant groups. Therefore, this study found particularly useful solutions around engaging with migrants by identifying them, proactively working with local groups, and providing language-specific advice about COVID-19 and service changes through multiple modalities. We also had a number of recommendations for vaccine delivery, such as co-design of delivery approaches, integration of interpreters and local community ambassadors, and provision of culturally appropriate translated vaccine advice. This study has since been published in BJGP and is featured in the BJGP Live podcast. Many thanks.